Hi, my name is Vint Blackburn. I'm a resident physician at the University of Pittsburgh Medical Center, as well as an attending physician at Western Psychiatric Institute and Clinic, and I was for a couple of years the assistant medical director for the Resolve Crisis Center here in Pittsburgh. And as a result, I've done quite a bit of teaching. Recently, I was actually doing a video presentation for the physician's assistants group. It was emergency medicine. And while I much prefer to teach in person and enjoy working where I can actually see my audience, I did think it was a good idea for me to try and put some of this on video and make it available to anybody who might be interested in some of the stuff I teach, as well as some of the perspectives I have. One of my specializations happens to be difficult personalities. I specialize in personality disorder as well as high-functioning autism. So a lot of that I approach very differently than a lot of my colleagues. I tend to be strength-based in the way I approach this, as well as using a lot of my background as an educator to try and look for those strengths. One of the things that I will talk about at some point is multiple intelligences, which is the whole concept of the idea that there's not one intelligence, but actually, kinesthetic as in the body, linguistic, mathematical, and that's something that in education theory we use a lot to try and find out what is helpful for an individual student or not. It actually works really well for patients as well. I also combine a lot of dialectical behavioral informed therapy in my work, and so that's something else that I'm going to be talking about in the future. But today I thought I would just start off with sort of an interesting introduction as to what psychiatry is. So obviously, for all my colleagues out there, this is something that we know pretty well. But it's really interesting because psychiatry is quite different than what a lot of people think it is. First of all, there's sort of a split that people are unaware of as far as between psychiatry and psychology. Psychologists, most of them are clinical psychologists, would be PhDs in psychology. They tend to focus on more of the psychological aspects rather than the pathological or medical aspects of psychiatric conditions. Psychiatrists can go both ways. I tend to be someone who does a lot of therapy as well as the medicines, but our training tends to be different. We tend to be trained medical doctors, so we do all of the anatomy and we work on how medicines affect the body, which is why we can prescribe. At the same time, I tend to be much more holistic in my perspective of how we deal with psychiatry. So one of the things that I would like to do is talk about that as well at some point. But the big thing that's really interesting to me is that whenever anybody finds out I'm a psychiatrist, somehow they think that I'm reading their minds or diagnosing them. There may be some truth to that, but the reality is I always tell people that if you're functional, you're not on my radar. And I think that's something that's really important because we tend to deal with people who are struggling in some area or another. And everybody has struggles and everybody goes through little bits and pieces of these kinds of challenges in their life, such as depression. We've all had some amount of it, especially lately with everything going on in the world right now. Or even things like people who are very superstitious. They're on that border of OCD in some ways because a lot of obsessive compulsive stuff is very oriented towards doing a ritual that will help you get rid of anxiety, much like somebody who is afraid that when a black cat runs across their path, they have to do something like spit out the window in order to erase the bad luck. My mom does that, but she's not sitting on my couch, looking for my assistance. So I think one of the things I'd like to point out as far as what we do in psychiatry is we take situations where they've gotten out of control, where they are interfering in our life. And that's what we're trying to focus on and work on. So a little bit of strangeness and oddness, that's everybody. What we try to do is take those things where it's truly interfering and see if we can help relieve those things. So it's interesting because the book that we tend to use for diagnosing is slightly different than the ICD-10 diagnostic manual that most physicians use to diagnose their disorders. So there's a book that has all these codes in it that would say, this code represents a heart attack with a lot more detail in it as well. We use the DSM, which is the Diagnostic Statistical Manual of Mental Illness. We're currently up to the 5th edition. There's been several little changes along the way. And it's interesting because it helps us generalize, or actually more codify, our diagnoses. So it used to be that when you would meet with a psychiatrist, if you wanted 5 different psychiatric diagnoses, then you might as well go see 5 different psychiatrists. So over the years, they have started to codify this, do you have a little bit of this, a little bit of this, and a little bit of this. But one of the things that's required for any diagnosis in psychiatry is must cause significant impairment. And that's where I think people misunderstand. If somebody says to me, I've got anxiety or I've got depression, and I say, okay, and they're going to work and they're paying all their bills and they're not having significant trouble in their relationships and they're essentially successful, but every now and then they get overly worried or a little anxiety. That's fine, but it doesn't mean that it's the same as somebody who has an anxiety disorder. So I think that one thing people have to remember, especially when they're thinking, are you trying to figure out what's wrong with me as you're sitting there talking with me, is chances are, if you're sitting there talking to me, not in my office, you're probably okay, certainly from my perspective. In some ways, it's actually allowed me to be far more relaxed in a lot of ways dealing with people. Because one thing I've realized for a long time is we all have characteristics, and we all have traits, and we all have personalities. And we're all struggling in one way or another. So I think that it's important to remember that when you think about psychiatry, psychiatric diagnoses, you think about how much damage or trouble it's causing you in your life. Or when you think about other people who are seeking psychiatric help or who are struggling, to remember that it's a spectrum. Just because one person has been sad or down or glum doesn't mean they really understand debilitating depression. And I think that that's something that I want to emphasize, because when it does get bad enough, whether it's depression, whether it's anxiety, whether it's superstition, whether it's not being able to ignore what seems like to most of us running thoughts in our head, but then they become externalized and loud and interfering and intrusive, then we're dealing with what we would call psychiatric pathology, or things that we need to deal with. And I think it's important to remember that just because we can relate a little bit doesn't mean we know what it's like also to be really, really ill. I often say that, being very depressed is like having a broken leg versus being somewhat depressed and mild, down, or is like having a sprained ankle. And so everybody has had a sprained ankle. But if you walk up to somebody who has a shattered, broken leg and say, oh, come on, walk it off. Get up. Come on, you just need to walk it off. That's ridiculous. This is the idea, is that at some point, some things that could be mild or tolerable become intolerable, and they become difficult to live with. That's when you end up seeking help. Of course, things like feeling so down that we don't want to be alive. Everybody has had those moments, I would say, of occasionally saying, oh, God, if I didn't wake up, I'd be okay. But that's very different than actually not wanting to be alive, which is actually much different than doing something to try and take one's life. So one of the things that I'm going to do, because I'm actually going to have a presentation on suicide assessment for non-psychiatrists, which would be most of the other clinicians, or even psychiatrists who aren't used to dealing with chronically suicidal populations, will be to remind everybody that almost everything is a spectrum in this field. And it's only when we cross over a threshold that it becomes something that we really need to take seriously and address. Otherwise, it's just the struggles of life. So anyways, this is kind of the thoughts I hope to kind of put down in video. Some of it, once again, will just be sort of thoughts and musings, and hopefully some of it will be practical information. And if it does turn out to be practical information, please let me know. I'd be really happy to hear about it. All right. Thanks a lot.